Hi everyone, and welcome to the Henry Schein webinar series on COVID-19. I'm Dr. Gary Severance. Today we're going to go right to Dr. Reznik for his clinical update. Dr. Reznik?
Good day and welcome again to the clinical update, and thank you, Gary, as always, for the kind introduction. It's always a pleasure to be with you and to share some of the latest information and things that we need to do to ensure that our practices remain successful, that our staff and our patients remain healthy, and that we do our part to ensure that people remain healthy. In other words, you can't be healthy without oral health, so we need to have our patients back in the office. So with saying that, the CDC just recently released some new updates to their guidance for dental settings. And most of these recommendations, to be frankly honest, are just a reorganization or simplification. The first is that they changed the measurement for fever to 100 degrees or above. Now, I did learn this from Gary before, that 37 degrees Celsius is 98.6 degrees Fahrenheit. And 38 degrees Celsius is 100.4 degrees Fahrenheit, and that's where that 100.4 came from. So in case you're wondering where that came from, like I was, Gary or Dr. Severance actually explained it to us. So right now they've changed it back to our Fahrenheit, so if a person screens and they have a temperature of 100 or greater, then that is something that we need to send for further screening. In areas where we have moderate to substantial community transmission, and regretfully right now that's most of our country, and we'll go over that shortly, during encounters with patients that we don't suspect to have SARS-CoV-2 or COVID-19, their recommendations have changed. And what I think I want to say about this is that right now I do believe we have to treat all patients as if they are suspected of having SARS. Even in the most remote and rural areas, I think we need to take the precautions, and the precautions are for our families, the precautions are for our staff and for our patients, and they make sense. So the newest thing is about wearing eye protection in addition to your normal masks or your N95s, because the eyes, nose, and mouth are all protected from exposure when you have splashing. And so glasses like I'm wearing now, these are my readers, they're not going to be significant enough. I have to have something on besides these. And so we wear face shields, a full face shield here. We have some face masks that work well with our loops, and so we have the coverage there so we don't have to worry about splashing or anything or aerosols getting into it. There are products out there that will literally help you with goggles, and again, talk to your local rep about what's the best thing to buy, but eye protection is important. Remember, this can go from mucosal surface to mucosal surface, so that's why we worry about the oral cavity and the nasal passages. We also have to worry about our eyes, and that is something that we need to do. So they did add added language that protective eyewear, such as safety glasses, trauma glasses, with gaps between the glasses and the face, you want to have those where they cover the sides so you don't get anything splashed. I think that is really important, and we don't really pay much attention to that. I sort of remember when I first started wearing face shields, those, the Opti-Ops kinds of face shields, and I have a wonderful assistant, and she does a great job, and I was amazed at the amount of splatter that would show up on the shield. So even with the best assistants, even with all of the extra equipment that we can buy, protect your eyes, and that way you're protecting yourselves, and make sure that your staff protects their eyes as well. So we talk about where this pandemic is in our country today. As you know, we're doing a great deal of testing, and we're finding a lot of positive cases, and it's gone from different parts of the country. But if you look at this map, you can see that the part of the country that I live in, which is the Southeast, I am in Atlanta, we have a problem right now. You might have heard on the news about some of the things with a school district that are going on, a camp that I'll talk about a little bit later that's happened. You might have heard that we've opened up the Georgia World Congress Center for overflow cases of COVID, just in case they are needed. So we're still considered a hot spot in Atlanta. And if you look at the darker colors on your map, those are the hot spots throughout the country. On the left part of the screen, you can see the top confirmed cases by county. And of course, it's the size of the county is going to have a a significant role in the number of cases. But you can see that even Clark County, which is in Nevada, has 44,000 cases. Dallas, almost 52,000 confirmed cases. And then you can look on the other side for more depressing news, which is the top 20 counties by the number of people who have passed due to this disease. So we really need to pay attention. We need to assume, I think, in the best cases that we might be susceptible to this virus, and what can we do to protect ourselves? So where is the direction of SARS? Well, I think one of the things we can say is we've seen some improvement. And last month in July, we averaged about 60,000 cases a day, which was a lot for us. If you look at the updated numbers from Johns Hopkins, it showed approximately 5 million cases since the pandemic began and greater than 155,000 deaths due to this disease. But in the earlier parts of August, we're beginning to see some improvement, and any signs of improvement to me are encouraging. We have several days of less than 50,000 cases being reported, and we still are doing a great deal of testing. So the numbers appear to be going down, and that's a great trend. Mississippi, one of my neighboring states, is heading for a title that no one would want, which would be to overtake Florida as the #1 state for new infections per capita. And this is research that's coming out of Harvard. What we heard from Dr. Birx is that what we are seeing today is different from March and April. It's extraordinarily widespread. It's into rural as equal urban areas. And I think that's also important. In Georgia, our first outbreak was not in Atlanta. It was not in Macon or Savannah. It was in Albany, Georgia, in South Georgia. And it had to do with a couple of funerals. So we had our first real major outbreak in my state in a rural part of the state. So I think that we need to take precautions whether you're in Atlanta, I'm going to use Georgia, whether you're in Atlanta or a smaller city in the state such as Columbus or a smaller area such as Athens. We really need to do what we can to prepare. We saw the Pacific Northwest being hit, and then the Northeast were hit as hard throughout the nation. Then the rest of us started to catch up. It went through the South. It hit us very hard, and the Sun Belt area very hard, and now we're seeing it go up into the Midwest. So what happened at that camp in Georgia? The CDC published an early release MMWR, and what they found was during June 17 through 20 at an overnight camp, which they refer to as Camp A, held orientation for 138 trainees and 120 staff members. The staff members remained for the first camp session scheduled from June 21 through June 27 and were joined by 363 campers and 3 senior staff members on June 21st. Camp A adhered to the measures put out by our governor that allowed overnight camps to operate beginning on May 31st, which included that all trainees, staff members, and campers provide documentation of a negative viral SARS-CoV test greater than or equal to 12 days before arriving. Camp A adopted most of the components of CDC's suggestions for youth at summer camps to minimize the risk of COVID-19. Measures not implemented were cloth masks for campers. So this is the first thing that was the red flag, that they didn't have cloth masks for the campers, and they didn't open the windows and doors for increased ventilation. One of the reasons is if you've been in Atlanta or in Georgia or Florida or any place in the South during summer, you know how hot it can get. Cloth masks were required for the staff members, but not for the staff attendees. On June 23rd, a teenage staff member left Camp A after developing chills the previous night. The staff member was tested and reported a positive test result the following day. That was on June 24th. Camp A officials began sending campers home on June 24th and closed the camp on June 27th. So this was a very fast reaction. On June 25th, the Georgia Department of Public Health was notified and initiated an investigation. The DPH recommended that all attendees be tested and self-quarantine and isolate if they had a positive test result. A COVID-19 case associated with Camp A outbreak was defined as a positive PCR test in a camp attendee from a specimen collected or reported to DPH from the first day of camp, June 17th for staff members and trainees, June 21st for campers, through 14 days after leaving the camp. So the trainees left on the 21st, the staff members and campers left on 24th through 27th. Out-of-state attendees were not included in this preliminary analysis. Just to give you an idea, it was a small number. It was 27 people. And they talk about attack rates. And attack rates were calculated by dividing the number of people with a positive test result by the total number of Georgia attendees. Remember, we're not counting those out-of-state folks, including those that did not have a test result. So we would include everybody. And then those that had a positive test we would include, but negative test results aren't really reported very often or consistently in my state. A total of 597 Georgia residents attended Camp A. The median camper age was 12, and 53% were female. The median age of staff members and trainees was 17 years old, and the range was from 14 to 59, and 59% were female. Test results were available for 344, or 58% of the attendees. Among those, 260. Let me repeat that. 260, or 76%, were positive, which is a remarkably high rate. The overall attack rate was 44%. So remember, we're looking at all of the campers that were in state. So 597. We had test results, positive test results for 260. So the overall attack rate was 44%. 51% amongst those aged 6 to 10. 44% amongst those aged 11 to 17, and 33% amongst those aged 18 to 21. So I really want to point out that, one, yes, youth can be infected, and youth were infected in this camp, and we probably know why. They didn't have masks on, and the ventilation wasn't addressed. In our dental settings, we wear masks. In our dental settings, we have ventilation, or we're working on ventilation, or we're getting equipment necessarily. So we're in a different environment, but I did want to bring this out because it has gotten a lot of news. Attack rates increase with the increasing length of time spent at the camp. So the longer your exposure, the more likely you were to have this. Staff members had the highest attack rate because they were the longest. During June 21st through 27th, occupancy of the 31 cabins averaged 15 people per cabin. So it ranged from 1 to 26. The median cabin attack rate was half, or 50%, among 28 cabins that had one or more cases. Among 136 cases with available symptom data, so this is just not PCR, but this is what their symptoms, 36 or 26% of the patients were asymptomatic. Among 100 who did report symptoms, the most commonly reported were subjective or documented fever, which is common, 65%, headache, another sign of this, 61%, and sore throat. Interestingly, what didn't make into the top three was the loss of taste and smell. So basically what we're talking about is that SARS-CoV-2 spreads efficiently in youth-centric overnight settings. It resulted in a high attack rate amongst persons in all age groups, despite efforts by camp officials to implement most of the strategies recommended. Asymptomatic infection was common and potentially contributed to undetected transmission, and that is what we need to watch out for in our dental offices, is asymptomatic transmission. Because many times a person will come in and then they could develop symptoms a few days later. So this investigation increased our knowledge base on the evidence demonstrating that children of all ages are susceptible to COVID-19 and, contrary to early reports, might play an important role in transmission. So this is something that we need to be aware of. Well, how does that sort of fit into what we're talking about today? If you follow the news, and I know that you all do, and you see how dentistry is involved in COVID-19, and I know you all do, then you probably have heard about some outbreaks in dental settings. To my knowledge, there has not been an outbreak based on clinical dental procedures. That has not happened. If we wear our N95s, we use our HEPA filtration devices, we do all of the recommendations that the CDC has offered, that OSHA has put in place, that the American Dental Association supports, then we will do our best to be able to keep that record of not having any transmissions based on clinical dental care. However, dental healthcare workers are people. We have lives. We leave the dental office where we're masked all day long. We go to our homes. Many of us, we basically stay at our homes and don't do a lot of socializing except going to the grocery store and mask and all that. But people do have lives outside of dental. And so we had 2 outbreaks, or I'm going to put quotes around outbreaks, at 2 offices in Colorado Springs, Colorado. The purpose of this list is, and this was from a release, the purpose of this list is to alert the public of local outbreaks so that anyone who may have been at an outbreak location can be aware and monitor their health for any COVID-19 symptoms. And this is from the El Paso County Public Health Department. Their definition of an outbreak was defined as 2 or more confirmed cases within 14 days with evidence of transmission within the facility. So it's a very specific defined. An outbreak is defined as 2 or more confirmed cases within 14 days with evidence of transmission within the facility. So what happened in these 2 cases? I'm basing this not on scientific literature, but I'm going to tell you what the offices said. And they're working fully with the Department of Health, and they're being completely cooperative, and they're being upfront with communication. And I can't stress enough how important the communication between us and our patients is. Patients still might be afraid to come in. We need to communicate. We need to do outreach to our patients. We need to stay in touch with our patients. We really need to follow the recommendations that we talked about through these series and that our organizations have recommended, where the American Dental Hygiene Association, ADA, or if you get that OSAP DentaQuest all-in-one kind of document, you really have that. But this was an example of an office or an organization using communication skills through social media to explain what happened. And therefore, I'm going to read their words. In the interest of full transparency, we would like you to understand the nature of the exposure in our office. While working with the county epidemiological staff on tracing, it has become apparent that one of our administrative staff members contacted the virus from a family member who was visiting from out of state. She was quarantined immediately upon showing symptoms. One other administrative staff member was sent home to quarantine after complaining that she didn't feel well. Her symptoms progressed, and she later tested positive while quarantined at home. No other administrative staff members have been symptomatic, and while not required by the county or state, we elected to have all of our administrative staff members tested for COVID-19, and their results were negative. None of the at-risk staff members related to this exposure are involved in the clinical treatment of patients, and per our protocols, they wear masks all day and social distance even for lunch. Nonetheless, we felt it prudent to test our clinical staff. Their COVID-19 test results were also negative. While the screening, social distancing, and personal protective equipment utilized in our environment make it unlikely that patients or their parents were exposed, it is important to know that there is some risk. We have been working closely with the El Paso County Health Department to perform the appropriate epidemiological tracing and provide notification. So this is an example of where someone had a family member who came, they became positive, there was a transmission within the facility. The organization took the proactive steps to communicate to the public as to what was happening. This was just the first of 2, and here is the second one I'd like to talk about. Again, these are their words, and I'm going to read them. To our patients and their families. As some of you may already be aware, several of our employees have recently tested positive for COVID-19. On Sunday, July 12, 2020, one of the administrative employees began experiencing COVID-19 symptoms while at home. This employee immediately began isolating and tested positive for the virus. In the following days, 4 other administrative employees experienced mild symptoms, isolated at home, and later tested positive. These team members only briefly interact or have no interaction at all with our patients in the course of their work. Other employees who work near them have tested negative for COVID-19. No other team members have had any COVID-19 symptoms. Because none of the employees who tested positive had interacted with our patients or their parents or work in the patient treatment areas, we believe that no patients or their parents were exposed to the virus in our office. Again, this is an example of it coming into the office and great communication to the public. It is clear that COVID-19 will be with us in our community for the foreseeable future. To keep patients and team members safe, we are taking extra measures to avoid spreading the virus. Since the beginning of the COVID-19 pandemic, we have carefully followed CDC, Colorado Public Health Orders, and Colorado Regulatory Agency guidelines for monitoring symptoms and testing, sanitizing, distancing, and utilizing proper protective equipment. We screen all team members twice daily, as well as patients and parents as they enter the building. We require everyone in our offices to wear masks and sanitize their hands for everyone's protection. We truly care about the safety of our patients, their families, our team members, and our community. We will continue to provide care at the highest standard of safety for everyone. Together, we will get through this. If you have any additional questions, please contact our office. Again, these are informative, heartfelt communication statements on an incident that happened in these two offices in Colorado Springs. They were notified, the word went out because of the state regulations on what they determine transmissions to be. Those two cases within 14 days, transmission within the facility. The offices went on the front and they communicated very well to their patient populations on what was going on. So what are those recommendations for isolation? I'm going to go over a basic screen here and talk to you about how we deal with this. For most persons with COVID-19 illness, so the majority of the people, isolation and precautions can generally be discontinued 10 days after symptom onset and resolution of fever for at least 24 hours without the use of fever-reducing medication. So remember, that was a change a while back. It used to be 72 hours, reduction, no fever without any kind of Tylenol or any kind of ibuprofen kind of medication. Now it's 24 hours. So 10 days after symptom onset, and resolution of fever for at least 24 hours without the use of a fever-reducing medication and with improvement of other symptoms. Some symptoms, like a cough, could last a period of time. Symptom onset is defined as the date on which symptoms first began. So you might have symptoms and then it's 10 days after symptoms, or it's 10 days after a positive PCR. For people who never develop symptoms, like I just mentioned, isolation and other precautions can be discontinued 10 days after the date of the first positive PCR test. So let's repeat it because it gets a little bit confusing. We're going to go over the next document. For people who have symptoms, 10 days after symptom onset and resolution of fever with 24 hours without any kind of fever-reducing medication. If you test positive and are asymptomatic, 10 days after that positive test. So we have protocols for house staff and household members to follow if someone is COVID-19 positive. These come from the American Dental Association. The first thing we really need to do is to perform a staff exposure risk assessment. So we want to identify other staff members in contact with the positive person, note the date of the last contact, and perform a contact risk assessment. What is low risk versus high risk? So a low risk is defined as prolonged or close contact to persons who are COVID-19 positive greater than 15 minutes within 6 feet, or other exposures. The appropriate PPE is worn. There's no work restrictions. Continue wearing appropriate PPE and monitor for signs and symptoms of COVID. So these are low-risk people. These are basically healthy folks. For high-risk people, again, prolonged close contact to a person with confirmed COVID-19 greater than 15 minutes and 6 feet, appropriate PPE not worn. So that means you've been exposed. Exclude from work for 14 days after last exposure. Advise staff members to monitor themselves for symptoms consistent with COVID-19. If no signs or symptoms, return to work and continue to use the proper PPE. Any staff member who develops symptoms consistent with COVID-19 should immediately contact their health provider and arrange for medical evaluation. So it just so happens in a program that I'm very close to, a staff member, their significant other tested positive. And so what do we do? Well, at this point, what my health system is advising, and this is giving you some additional information, is that staff member can come to work as long as they are masked and screened, and we screen here once a day. We screen on the way to work. They've also been talked to by me and the deputy medical director should any signs and symptoms we need to know, and we've already scheduled their test. But right now they are at work. So we have an exposure we're actually dealing with and how we're dealing with it here, and we're monitoring the situation very closely. Why do I bring this to your attention? Because we are human. We're dental healthcare workers, but we have contacts with other people. We don't know how other people are behaving during the day, and there could be burnout to a degree. We're wearing these masks all day long, or these respirators all day long. We're in these hot gowns or coats. We're constantly moving and overheating, and maybe we get a little burnout and we say, okay, I need to take my mask off. If you get to that point, go outside. Go into a ventilated area. Make sure that you can, take some breath. But we can't always be responsible for everybody in our worlds. So there are going to be people who test positive in our programs. And it could be administrative staff, it could be clinical staff. And as long as we're following these guidelines from the ADA, as long as we're following CDC guidelines, everything will be fine. There's a protocol to follow that the ADA has put together for you. If a household member is positive, if the staff member has confirmed or suspected COVID-19, you can look at the different directions in which it goes. If the staff member, their coworker is unknown, we do the staff risk assessment. If they're high risk, in other words, immunocompromised and had a long exposure, we might put them in quarantine. This is just to give you an idea of what the American Dental Association is recommending. If the coworker status is unknown, we do the risk assessment, and that's what we do on everybody when they come into work, just like we do on every patient that comes into work. So we're really not doing much different. If the staff member's COVID-19 status is unknown, you can quarantine. That's a recommendation if they've had a high-risk exposure. Remember, if they get tested and it's then 10 days after the test, if they have symptoms and they're symptom-free for 10 days, and then 24 hours without having a fever, without medications, they can come back. So if they're low risk, there really are no work restrictions. I have no work restrictions on the staff member. We're just monitoring for signs and symptoms. If signs and symptoms do appear with the staff member, we will have them immediately, if they test positive, of course, they will be quarantined. If they have symptoms, they will go into home quarantine. So this just gives you a sort of pathway to work to as you're working through how you're going to manage your patients. So self-quarantine and return to work strategies. So what's somebody who is symptomatic, who has mild to moderate disease and illness, not severely immunocompromised, at least 10 days since the first symptoms? I know I'm repeating myself, and this is what we've been talking about. Severe to critical illness, or they're severely immunocompromised. So we have somebody who's very sick in the hospital on respirator, etc., at least 20 days since the first symptoms appeared. At least 24 hours since the last symptoms of without fever-reducing medication and improved symptoms. For asymptomatic, not severely immunocompromised, at least 10 days since the first positive viral diagnosis. For a severely immunocompromised individual, at least 20 days since their first viral diagnostic test. I work with an HIV population. People who have HIV disease, who have undetectable viral load, are not considered severely immunocompromised. So they would be considered not severely immunocompromised. So test-based strategy, if you have a symptomatic person who has a positive test, again, it's written down here for you. Negative results of an FDA-authorized PCR test are required. Asymptomatic, the same. So it just gives you, again, what the American Dental Association has laid out as potential strategies if someone is positive on your staff or someone is positive, a family member or a close associate is exposed. There are a list of guidelines here, return to work guidelines from the CDC. All of this information is from the CDC, so employee risk assessment is here for you to use. Contact tracing, what health departments use, is here to use. Disinfection, we've gone over a great deal, and I know you're probably tired of hearing some of the ways that we do that, but that, again, is a CDC recommendation. And OSHA reporting work related to COVID transmission. OSHA revised enforcement guidelines guidelines of recording cases and the American Dental Association summary of reporting work-related COVID-19 illnesses to OSHA. So we have all of the legal documents that you need here, and they're accessible for you. Again, communication. As you saw from earlier in this presentation, the two pediatric and the one pediatric ortho office in Colorado Springs were very proactive. They communicated not just through social media, but they probably have been doing a great deal of communication with their patients. And we're treating our patients differently. So reaching out to patients and explaining how some of what we're seeing is different is something that we probably need to talk about with our patients, to tell them that we're taking all these extra steps to ensure their safety, our safety, and great health outcomes for everyone. So here is another example of the work that OSAP has done in combination with the DentaQuest Partnership for Oral Health Advancement. People need to know that COVID-19 is changing how we do what we do. And so we have a document here, what steps are being taken, and this is the ADA document to help you make sure that you're feeling safe. Other people have come up with other documents that you can use as mail-outs. I know the American Dental Association has a wonderful document on what to expect that we've covered earlier, that you might be waiting in your car and that we might text you when it's time to come in, etc. So we've had a long history of dealing with infectious diseases. We follow our rules from health experts. We communicate that to our patients, and that's what things that we'll do to keep them safe. So we clean all the surfaces. They need to know that. They need to know that we're cleaning the waiting rooms, and the waiting rooms might look different. We've replaced plastic devices. We've gotten rid of newspapers and magazines. There won't be as much entertainment in the waiting rooms, nor will there be as many people. They'll see us wearing masks and goggles and face shields and disposable gowns and lab coats, etc., etc. Possibly bonnets, footies, all the different kinds of protections that we can do to ensure our safety. They'll have new procedures. We need to let our patients know. We've invested in HEPA filtration, portal HEPA filtration units. Other offices I've known have gone to central HVAC HEPA filtration units. We're using the chairside aerosol evacuation units. We're trying to take every step possible, and we want to communicate to that patient so they feel safe coming to us, so we can do what our important role in the healthcare of those we serve. So before you go to the dental office, and this is something we need to tell our patients or let them know in advance, you could do a mass mail out at a time like this, which is a great way of getting your information out. It's also a great way of staying in communication with the patients that you have served all these years. So let the patients know that the dental office may call you 1 or 2 days before your visit. They might ask how you're feeling. They may ask if anyone in your household has COVID-19. They may also ask you if someone feels sick and they don't know. If you or anyone in your household is sick, the dental office might set up a visit for a different time. We're trying to keep everyone as safe as possible. Patients getting certain treatments may be asked to obtain a COVID-19 test. I had to arrange for a patient to get a biopsy by my colleague at ENT. Before my Emory colleague at ENT could do the biopsy, the patient had to have a PCR for COVID-19 before that procedure was done. You may be asked to not bring anyone with you, or in the case of the pediatric office, maybe just one parent with the child. And then if you need someone to help with different languages, maybe one person. But the whole idea is to limit the number of people that are coming into the office. We could also let our patients know what some of the signs and symptoms are, although they probably have been hearing this to death on their nightly news about shortness of breath, cough, fever, headache, loss of taste of smell, etc. Once you're at the dental office, they may call or text you before you enter the office to reduce the amount of time you spend in the waiting room. We're actually rescreening once they get into our building. We're rescreening people before they even enter into our waiting room. You may be required, in our case, you have to have a face mask on to enter our building. You have to keep the face mask on while you're in our building. Not under the chin, not under the nose, not on top of the head. Needs to be worn properly. Every time I walk down the hall, I feel like I'm turning into the face mask police with our patients, just making sure that they stay safe and that we stay safe. Once inside, you may be asked the same questions that you were asked on the phone all over again. They may take your temperature like we do. If you do not have any signs of being sick, you will either be asked to sit in the waiting area or directly into the treatment room. So those days of waiting to get to see us maybe are gone, and we'll have a faster turnaround. We might ask you to use hand sanitizer. We do ask you to use hand sanitizer. You might be asked to use a pre-rinse, which is something that we're doing. And so there are all these different things that we're doing that we want our patients to know that we're taking all of these extra steps to regain or maintain our confidence. In the treatment room, the dentist and dental staff may wear special clothing that they haven't seen before. They may wear a special type of mask. They may wear a full face shield. They may have coverings on their hair and feet. They may wear, will depend on the level of risk in your community. It also depends on the type of treatment you're having. There may be some equipment in the room to circulate the air, some of our new equipment that I've talked about. Air filters may be used. Some dental offices may open windows during treatment. The dental chair may be in a different position for better airflow. So we're really concerned. We're maybe opening windows. We're doing things to make sure the air exchange rate gets higher so that we are as safe as possible. The way the treatments are being done may be different, and it really different. We're for the most part, trying to avoid doing aerosol-generating procedures, but where we are, we might be putting on rubber dams before we do our restorations. We might be doing pre-rinses. There's all sorts of things that might be different than we've been doing in the past, depending on the amount of spread of the disease in your community. After your visit, several days after that you come in, your dental office may call you just to check on you. You may be asked if you are sick to contact the office over the next 2 weeks. So it's something that, again, maintaining that communication. Some parts of dental care have changed because of COVID-19. Your office, your dentist, is taking steps to ensure that your dental care is safe and effective. Your dental care should protect you and your dental staff from getting sick. So again, communication is key. We're still in this. When we started this pandemic earlier this year, I honestly did not know that I would still have the opportunity to speak with you about clinical developments and things that we can do to maintain safety among our patients. It's been an honor to be able to communicate with you the latest information. Again, if you have any questions, please do not hesitate to let us know. I'm going to turn it back to Dr. Severance once again, and thank you for your time and attendance.
Thank you, Dr. Reznik, for that clinical update. Now, as always, if you have any comments, questions, or subjects for future episodes, please email us at webinars@henryschein.com. And please subscribe to our YouTube page by clicking the subscribe button below. Until we see you again, stay safe and stay informed.